Hello, my friends. I'm sorry I can't be with you today. I am actually being trained to give the end of grade and end of course tests. So I am working with my team. But while I'm gone, I wanted to give you just your last Unit 5 class. So I want to make a video for you. So we're going to be talking about stress, mental health, and treating psychological disorders today. Sorry. So, of course, our vision, mission, and Class Connect Fab 4, which I apologize, I am covering. And I just want to remind you that from April 24th to May 5th, there will be no live classes because your teachers will be administering the tests. And the live classes for this class will begin Tuesday, May 9th, or Wednesday, May 9th, May 10th for my other class. So we'll start studying for the 5.05 test. Of course, you don't have to wait till then to take it, but if you want to study first with me, that's when I'll do it. Please make sure you check your calendar. You will see there is a review unit called Review of Approaches listed in Instructional Cycle 3, and there are some things that I'm asking you to do in there. So the 5.04 essay was due Wednesday the 19th, but there is also some essays the 24th. There's the 5.04 essay, an Ed Puzzle video. You can watch all of them, but you only have to choose one for a grade. And then an essay due Monday, May 1st called How Would You Approach It? If you notice this essay in Unit 1, I decided to put it to the end and see if it was more comfortable this time. Unfortunately, we can't be together to learn about the fabulous Joel P., but I wanted to go ahead and share with you his slide. So as you can see, Mr. Joel has a lot of things that he likes to do, and I have to say I was very excited to see The Outsiders there. I'm not much of a Lord of the Flies person, but I love The Outsiders, one of my favorite books. So here he is with his friends or family, I'm not sure which, maybe two brothers. He says he's the middle child. He'll be 17, probably by the time of this recording. He likes to write. He writes novels and fan fiction under the name Hero Boy 005, scripts and drabbles. I'm not sure what a drabble is, but feel free to enlighten me. He likes to sing, read, and act, which is awesome. He's a born-again Christian, been to Frankfurt, Germany. He's about to go to Cork. Actually, by the time of this, he will have gone to Cork, Ireland, so I look forward to hearing all about those things. His favorite movies are Kung Fu Panda. I've thrown a few Kung Fu Panda in for him. The Passion of Christ, Star Wars Episode 5. I like that you picked a specific Star Wars. A lot of people don't, which is fine. I like them all. Zootopia. I love that one. Lion King. Hitchhiker's Guide to the Galaxy. I've never seen the movie, but I love the books. I have the his worst named trilogy ever. It's 5 books in the series. Spider-Man, Aliens, Guardians of the Galaxy, whoop whoop, and the Magnificent Seven. And he loves the Bible, The Outsiders, Lord of the Flies, The Giver, Gathering Blue, Escape from Furnace, and Cricket Man. I have to go look up some of those. I've not heard of them, so you might give me some new books to read. He loves Red Hot Chili Peppers, Owl City, Nico, and Vins. So many different groups there. I'm gonna stop, but I love to listen to the soundtracks of movies myself, actually, and also to Disney songs, as I admitted in class. So lots of awesome things to learn about Mr. Joel. I will give you a round of applause since I can't do it in the classroom, but thank you very much for sharing, my friend. All right, so what are we going to do today? Well, according to the brain, we're going to try and take over the world, but bad news, brain, not today. We will look at how each approach would treat a patient. So we're going to go through the major approaches and kind of consider how they would be treating patients. We'd also like to think about what type of disorder or person would respond best to each approach, because not every person would do that. And unfortunately, still no world domination. So we will be thinking about some possible career paths in psychology. So in the chat box, we would list some careers a person who majors in psychology might take if we were in class. Obviously, we're not there. We're not going to do that. Sorry if you noticed a brief interruption. I was just checking something. But I thought for fun, we could talk about the people who treat psychological disorders. And generally, if your psychological disorder does not interfere with your everyday functioning, some people don't ever really receive treatment. They may not even know they'd be classified as having one. But people whose disorders reach a point that they can't function normally, they may need some kind of treatment, anything from being treated as an inpatient in a hospital, outpatient, seeing a doctor, lots of different things. So we'll play a little Who Am I game, and our first person has a doctoral degree, a PhD, and a license, and can help treat disorders but doesn't usually prescribe drugs. Who would this job be? Well, if you said psychologist, you would be correct. Our next person who might work in the psychology field has a master's and possibly a PhD in psychology or counseling with a license. This person would work in schools or businesses by listening and assisting with everyday problems, but generally refers more serious situations. So who would that person be? If you said counselor, you are correct. All right. Who would have gone to medical school and specialize in mental disorders, have a license, treat disorders, prescribe drugs, and perform operations? Can you guess? You said psychiatrist, you're correct. Last one. This person has a master's degree and possibly a PhD in social work with a license, helps people with everyday family problems, but generally, again, refers more serious situations. That would be a psychiatric social worker or a nurse. So you may not have realized, but nurses or social workers can actually specialize in different forms. And in this case, this is a psychiatric social worker. I do have a video for you. I will include that video alongside this one so that you can learn more about different types of careers in psychology. It's pretty cool what's out there. All right. Now, what do you think would be the most popular approach of psychology in treating disorders? Would you say behavioral, cognitive, humanist, or psychoanalysis? And remember, you're not saying it's the only one that would ever be used, but which one do you think is the most popular, the most likely? Well, take a look at this chart, my friends. Believe it or not, behavioral is actually a very, very rarely used because it only treats very specific things. Cognitive, you see here. Psychodynamic, which is psychoanalysis, is a big one that's used, but the most commonly used is the eclectic, meaning a combination of the different groups. So as we mentioned before, don't get hung up on just one approach. Most good psychologists will be able to switch between approaches depending on the need of their patient. Because as you're about to see, um, not every disorder is treatable the same way. So let's talk about that. All right, I'm going to move myself back over here. I'm going to jump around a lot today. Remember our friend Sigmund Freud? He came up with the psychoanalytic approach. And he's the one to kind of postulate that a lot of disorders come from childhood experience and inner conflict. And these inner conflicts come from the id fighting with the ego. So that pleasure area that wants, has certain needs, aggressive urges, fighting with that more rational area that's like, no, you're not going to behave like that. Psychoanalytic psychologists, also called psychodynamic psychologists, try to reduce the anxiety of their patients by having them become aware of their unconscious conflicts. So when you know how your id and your ego are fighting, you're better able to say, here's what I need to do. And Freud calls this gaining insight. So this is a big part of the psychoanalytic approach. There's a few different techniques that a psychoanalytic psychologist could use. One is free association, which we've used before, where you just ask them to associate, you give them a word or you give them a phrase and just let them say whatever comes to mind. And what a psychologist or a therapist is looking for is resistance. Where do you say, oh, I don't want to talk about that, or no, that's not what I meant, where you refuse to get into something, because that's kind of where the root of the issue might be. Dream analysis. According to Freud, our dreams are all about our unconscious. What we see in the dream is called the manifest content, and we talked about this before, so this may sound familiar. So let's say, for example, I see myself on a motorcycle with an alligator. Okay, the alligator and I are riding on the motorcycle together. That's my manifest content. But the question is, what does it really mean? What is my latent content? Maybe that motorcycle really represents my life, and that alligator represents some kind of obstacle or some kind of fear I have about my life. So the latent content would be, what does the dream actually mean? Of course, maybe I just really like motorcycles and alligators. It's hard to say. And then transference. Sometimes when you have a feeling about another person and the psychologist gets too close to it, you might get kind of mad at your psychologist or get mad like at your mom, but really you're upset at someone else. And so that's another thing the therapist will look at you for. Okay, why are you really mad? Is it me? Or is it possibly you're really mad at someone else that you can't direct your anger towards, so you're directing at me or directing it at a family member? So transference is a big one that a psychoanalytic psychologist would look for. Keeping in mind, see if I'm in the right, oops, sorry, whoa, wrong side. Okay. Well, as I mentioned before, according to Freud, the id is that thing that is always driving us, always pushing us. And here the id is actually much smaller. Oops, sorry. I'll let you see that in a second. Here the id is a lot smaller, but it's the thing that's below water. It's the part that is always pushing for gratification. Some people think it's bigger, some people think it's a little smaller. It's the one that has all your needs and your wants. It's hungry, it wants food, it's thirsty, it wants water, it's angry, it wants sex. It's the part that's always pushing you. And because of that, when you don't meet some need, there's a war between your id and your ego. And as I was hiding over here, the pleasure principle is to the id and the reality principle is to the ego. So let's say you're hungry, but you know you can't get lunch right now. You might be grumpy because your id is like, I want lunch, give me lunch. And your ego's like, well, not right now. So you have that kind of that balance going on. Now, psychoanalysis is really good for people who are verbal, who are educated, and who only suffer from mild depression or anxiety disorders. It's not going to work for someone who's schizophrenic, for example, or someone who doesn't communicate well. But here you can see that constant battle between the id and the ego, partying versus studying, let's say. All right, moving myself back over here, excuse me. Let's talk about humanism. Moving on. As you remember, Abraham Maslow made that chart of the needs that we have, and each time we fulfill a need, we move up on the pyramid. In humanism, a patient is called a client, and it's the job of the therapist or the doctor to help the patient reach their full potential. And remember, like we said before, it's not about perfection, it's about getting to be the best that you can be. So the two things that a humanist psychologist would want to focus on are self-awareness and self-confidence. So the therapist and the client are equals. The client really guides and directs the therapy, but it's the job of the therapist to kind of offer insights or help the client to make decisions and then kind of back off and let the client decide where they will go. So it's all about free will and the client making the decision. Now, one therapist who's really made a lot of breakthroughs in the field of humanism was Carl Rogers. He created a very client-centered therapy. So again, letting the client being in control, letting the client direct everything. He said that the only way you can do this, there's three parts. First, you have to have genuineness. So the therapist and the client have to be completely open and honest, which means that if the client asks the therapist a tough question, therapist has to answer it. So this is really revealing for both the client and the therapist. There has to be a very unconditional positive regard. If the client says something that might be unusual or maybe like admits to thoughts that are dangerous, like I want to kill somebody, the not that we hope that they would, but the therapist can't say, ugh, I can't believe you did that. It always has to be very positive, always be unconditional. Okay, let's talk about that. Okay, let's see what's going on there. Very accepting of the client so that the client feels that they have confidence. And empathy. Always be very understanding of your client. I mean, let's face it, we've all had days when we're very angry and very upset and things haven't gone our way. Maybe the client doesn't really want to kill someone as much as they're just so frustrated they need to get that out. So having that emotional understanding. Who would benefit from humanistic therapy? As we said before, it is the client. I'm sorry, let me say that again, who should decide the problem in the treatment? I was not paying attention. Sorry about that. The client should decide. The client is always in control. And if you look at this chart I have about the therapist's perspective, where therapy happens is when the therapist perspective, the therapist can keep into their mind what they know about themselves and what they believe about the client to be true. Okay, that's very important. When you start getting into a danger areas when there's things you don't know about yourself as a therapist, or if you've got things that you believe about the client that turn out to be untrue. So the therapist wants to kind of stay here. Keep in mind what the therapist knows about him or herself, and then what he knows about the client that is true. So the types of treatment that you might use with humanistic therapy: active listening, repeat what the client says, rephrase it, ask the client to clarify. So you're listening, but you're also really making sure that you're focused on what the client says. And it's most effective with anxiety disorders, mild depression, or mild social disorders. So again, not the really serious disorders, but generally disorders that can be spoken about, especially with an articulate client. As I just mentioned, a more educated client generally. All right, so how about the cognitive approach? Well, we can talk about there's really two major focuses with cognitive. One is the rational emotive therapy, which says that most of us have false concepts. We have things that we've learned that are not true. And if we confront someone, a client, with an irrational belief, they can see it's irrational and they can change it. So if the client is convinced the sky is green and we prove to them that the sky is blue by holding up a blue piece of paper, the client can say, wait a minute, maybe I'm wrong. The therapist is like a teacher in cognitive psychology, and they kind of help that client develop their skills to think more rationally. So it's very much about reason and logic. Aaron Beck created something called the cognitive restructuring plan. In this one, there is no challenge to the client's thoughts. So instead of confronting the client with a rational belief, you don't challenge them, but you just ask questions and you help them to think their way through something and help them to kind of test their own logic. So you let the client be more in control of testing their logic and developing a more logical way of thinking. So instead of saying, well, well, look, here's a blue piece of paper. Are you sure that sky is green? You might say, okay, well, that sky's green. All right, sure. Okay, well, what do you consider blue? Let's look for something that's blue, and then kind of help them guide themselves to that understanding. With cognitive restructuring, there's actually homework. Can you believe it? Clients have to fill out forms about their responses to everyday life events to kind of keep a track of what they're thinking and how they're thinking. Depression and anxiety and personality disorders work really well if the person, oh, sorry, I put that in the wrong order, if the person wants to be involved and do the work required. So when you have someone who's not interested in doing the work, you're not going to get very far. All right, behaviorism. When do we want to use behaviorism and what do behaviorists do? Well, you can see here's the ABC of behavioral learning. You have the antecedent, which is the thing that happens to cause the behavior. And then once you have a behavior, if it's not a good one, you have a consequence, which will lead to provoke another situation that will bring another behavior. So behaviorists are looking to break this cycle. The goal of behavior therapy is to modify and help people learn more adaptive behaviors. And the belief is that behaviors are learned. So therapy believes that they can change the behaviors by changing the consequences. So they can show people how their behavior is not helping them to do well in the world. There are 4 different types they can use: systematic desensitization, aversion therapy, extinction, and token economy. So we're going to talk about each one. Remember Mary Covert Jones and Peter? He was afraid of rabbits and she gave him candy till he was willing to come up to the rabbits. Well, that was systematic desensitization. And this is the use of classical conditioning to take something you're really afraid of, and then you take a hierarchy and you rank situations where you're really afraid down to situations where you feel really comfortable. And then through using relaxation techniques, through using things that you like, you pair them with the items in the hierarchy, starting kind of at the bottom with the least fearful, all the way up to the ones that are most fearful, until eventually you work your way up to conquering the fears that were really the worst. Now, you also can use aversion therapy, which is where you replace a positive response to a stimulus with a negative response. And by positive and negative, I do mean good and bad here. So for example, if someone enjoys smoking a cigarette, but you show them a yucky, nasty ashtray and you put their food on it and say, here's what you're eating out of, oh, now they're associating that cigarette with a more gross, disgusting ashtray. And each time they reach for that cigarette, they might think, oh, I don't know if I want this anymore. So you're replacing that positive with the negative in terms of the good and the bad. I know I confuse you with positive and negative. All right. Sometimes you want to just get rid of a behavior, and that's where you need to use extinction techniques. So you remove the reinforcements for an undesirable behavior. This comes out of operant conditioning. For example, if a child misbehaves to get attention, like starts yelling and screaming, and you ignore the child every time they start doing that, over time, that attention should go away. Of course, keep in mind, younger children can be pretty stubborn, so it may take a while to get it to go away. And then there's something called a token economy. This works really well with people who are in like inpatient treatment or maybe in outpatient treatment where they're rewarded with points or a coin that they can accumulate to earn a larger reward. For example, schizophrenics who are in hospitals often respond very well to token economies because each time they do well, they get something they can touch and feel and see, and it's of value to them because they know they'll get a bigger reward. Children, by the way, token economies. Here's the gold star each time you behave. So the psychological disorders that would benefit the most from behavior therapy include phobias, PTSD, compulsions that people might have, as well as, like I said, managing people living in institutions. The token economy is really useful, especially for schizophrenics, because they can distinguish reality from lack of reality if you give them something they can touch. All right, neurobiology. When we talk about biological therapies, we're generally talking about drugs. And if you think about it, drugs have their good side, but they have their negative too. So we want to think about how they can help, but also how they could cause problems. This generally takes the form, like I said, of drugs, but also electric shock or even surgery can be included. Drugs are generally the most common therapy used. And like anti-anxiety, antidepressant drugs are very common. Lithium and antipsychotic drugs are less common in terms of types of drugs. Anti-anxiety drugs work by depressing the activity of the nervous system. They don't cure anxiety, but they help the patient to kind of reach an equilibrium, or at least to feel like they can monitor and maintain their anxiety instead of letting it get out of control. Antidepressants are very commonly used with a lot of people who have mild to severe um, psychological disorders, depression, eating, panic disorders, and generally they work with neurotransmitters. Serotonin and norepinephrine are the most common. When you get to higher levels, you do need to watch patients because there is a chance for overdose. All right. Bipolar generally does well with lithium carbonate, which helps kind of flatten out that cycle of woo, high euphoria and then crashing down to depression and kind of keeps them calmer. It does have the side effects of shakiness, memory impairment. Sometimes you can't remember what you did the last day, and even excessive thirst. So like I said, it can help, but it can cause problems. And last but not least, antipsychotic drugs like major tranquilizers to help reduce agitation, delusions, hallucinations. They often block the activity of dopamine, and they are now being shown to reduce both schizophrenic symptoms and Parkinson's disease. So some antipsychotics are given to reduce like Parkinson's disease instead of a psychotic issue. Now, another treatment that is not used as much but still does have some effect and is therapeutic is electroconvulsive therapy. It was originally called shock therapy, began in the 1930s, and in the beginning it was often used with very high dosages and the person would break their teeth or they'd convulse and it was just considered barbaric. But there are ways that they can be used now, like anesthetics can be given to kind of so the person won't tense up and reduce the severity of the convulsions. And generally, if it's used today, it's used for major depression when any other method has failed. So it's a last resort for somebody who just cannot, no drug is working with their major depression, they just can't get past it. And it just kind of pushes, it's like it rewires the brain, and the brain stops being so negative, or it produces more neurotransmitters. Remember the thalamus, our friend the thalamus? It relays those signals from the senses to the frontal cortex, and it's involved in the wake and sleep cycle. And the prefrontal cortex, which we haven't talked about, but this is involved in planning complex cognitive behavior. It's involved in our personality, our decision making, and moderation of social behavior. On occasion, there are times when the thalamus just either sends too much to the prefrontal cortex or nowhere near enough, but there's a miscommunication that can cause anything from seizures to hallucinations. And on those rare occasions, there might be psychosurgery considered. It is a brain surgery that people might use to treat psychological disorders, and it's generally known as the prefrontal lobotomy. So you just separate that frontal cortex from the thalamus. It is very rarely used. For one thing, it leads to a lot of problems with distractibility, apathy, seizures. Sometimes you're not really able to express yourself after that. And it's extremely controversial, even more so than electroconvulsive therapy. It's generally used when, for example, a patient's having seizures and nothing has worked, and the seizures are getting to the point of deadly. It's not used as a first resort. It's generally used as an absolute last resort when nothing else has worked. Because as we've learned, the more you tinker in the brain, the more problems you can cause. All right, my friends, if you can believe it, that's it. Hopefully you have a better understanding of how each approach is used and where that approach can be more useful. I will see you after the end of course, end of grade tests to review for the 5.05 test. And after that, we go straight into IA3, the final exam. So it's hard to believe the end of the semester is coming. Thank you, my friends, for watching, and let me know if you have any questions. I look forward to seeing you after the tests.